allowing me to share some of the work that we've done using data from Burkina Faso, as well as work that we did as part of the Anemia exemplars using Senegal as a country case study. And I'd like to acknowledge both my colleagues at Impact for their feedback on the Burkina Faso work, as well as thank the exemplars and global health team, specifically Dr. Zulfi Putta and Dr. Ndiye Fatou, for allowing me to present the results from Senegal on their behalf. I have no conflicts of interest to declare. So I had a more detailed presentation where I was going to talk about the items you see outlined in this slide, but I'm going to skip a lot of the background slides in the interest of time and hopefully give you some time to ask questions. One caveat, this is very statistics heavy. So I will try to go slowly, but please ask me questions here or just stop me if you see me around the hotel, and I'll be very happy to talk about the analysis that we did. So we're all very familiar with causes of anemia, so I'll skip this. So I'll jump right into the approach that we use to build the anemia model. So to build our hierarchical model, we use the approach that was proposed by Cesar Victora and his colleagues back in 1997, which basically allows the multivariate hierarchical model to handle complex hierarchical interrelationships between multiple disease components. Specifically, it also allows for control of potential confounders, and then the variables retained in the multivariate model are not based on just statistical significance, but you also take into account biological plausibility, the country context or the population context that you are working with. And then finally, you are also able to assess the direct effects of the more distal determinants, or those factors that are further away from anemia as the outcome, and to assess their effect on anemia, which is likely mediated through more proximal factors. So for example, if you were to include all the different factors that are in an anemia conceptual framework, some of them will not be retained because their effect is being captured by some of the more proximal variables. So this approach may also highlight the impact of public health programs and policies that affect the more distant determinants, as I said. For example, social assistance programs such as cash incentives for households or investments in community-based treatments of infections, for example, insecticide-treated bed nets on anemia, which otherwise may be obscured because the impact of these programs and policies are mediated through the more proximal or nearer factors on the conceptual framework, which in this case would be the reduction in infection burden. So here I have a very simplified conceptual framework with anemia as the outcome, and the model is looking at the effect of household wealth and how it potentially impacts anemia burden. So in the hierarchical approach, we would first assess the impact of household wealth on anemia by itself. Then in the second level, we would include the variables that capture the prevention and treatment of infection. And then finally, in the third model, which would have variables from the first and second level, altogether will give you a more complete picture of how these three different levels of variables can affect anemia as an outcome. So I will jump right into some of the results for Burkina Faso, and I hope this stays. There we go. These are all slides that you will have access to, so this is just a brief description of the data and how the data were collected in the Burkina Faso survey. So for building our statistical model for Burkina Faso, we started our regression analysis by looking at the bivariate association. Maybe one more slide. Okay, here we are. So we started our regression analysis by looking at the bivariate association between each of the three outcomes, specifically anemia, iron deficiency, and iron deficiency anemia, and the variables on which data were available in the Burkina Faso National Micronutrient Survey. We only looked at those variables which had a coverage or prevalence of at least 2%, and for a potential determinant to be considered in the hierarchical multivariate model, we used a p-value cutoff of less than 0.2 for the women and children, and a cutoff of less than 0.25 for the adolescents. To build the hierarchical multivariate model, we assigned all the variables being considered for analysis to one of the three levels shown on the right-hand side. The first level was underlying causes and included household wealth, urban-rural residence, food security, etc., and that was followed by the immediate causes, which include diet, micronutrient supplement intake, as well as the prevention and treatment of anemia. Of infections. And finally, the third level is where we included biological causes, such as iron and other micronutrient deficiencies, malaria and other infections, as well as inherited blood disorders, which we had collected data on among women and children. Additionally, for a variable to be retained in the multivariate model, we defined statistical significance at a p of less than 0.15. So this slide just shows how each variable was assigned to a hierarchy. And then for the hierarchical multivariate model, we ran 4 logistic models to arrive at our final multivariate model. In the first model, we assessed all the underlying causes, which had a bivariate p of less than 0.2. In the second model, we retained those underlying causes which had a p-value of less than 0.15 in model 1, and assessed the immediate causes which were associated at the bivariate level. And then in model 3, we retained the underlying and immediate causes which had a p-value of less than 0.15 in their respective model, and assessed the anthropometric indicators which were associated at the bivariate level. And finally, we assessed the biological causes, having retained the underlying, immediate, and anthropometric indicators. And our final hierarchical model included underlying causes with a p-value of less than 0.15, immediate causes, anthropometric indicators, and the biological causes. All were retained with a p-value of less than 0.15. Okay. So this slide summarizes the results of the modeling we conducted for children in Burkina Faso, children 6 to 59 months, specifically looking at anemia as the outcome. As you can see, I'm not sure if you can see very clearly, but the proportion of women who had ever attended school, or in other words, maternal education, was found to be protective against anemia for children aged 6 to 59 months, as well as the household having access to improved water and sanitation services. If a household practiced open defecation, the child had higher odds of anemia, as you can see on the slide. Among the immediate causes, we see that the burden of anemia among women 15 to 49 years, which we considered as a proxy for maternal burden, as well as pica practices, were associated with higher odds of anemia among children, while consuming ready-to-use therapeutic foods or nutritional supplements were protective. Child age was not associated with anemia, but we retained it in the model to control for residual confounding or for any unmeasured covariates in our data set. A child having stunting was the only anthro indicator associated at the bivariate level, and it was also retained in the multivariate model. And of the several biological correlates that we identified at the bivariate level, only iron deficiency and vitamin B12 and serum folate deficiency were associated with anemia. And last but not least, we also saw that if a child had tested positive on a rapid test kit for malaria, the child had higher odds of anemia. So since we had the data on iron deficiency as well, we also looked at what the correlates were for Burkinabe children with iron deficiency at the outcome. So as you can see on the model presented here, none of the underlying causes, which were the household wealth, maternal education, etc., wash variables were not associated with iron deficiency as the outcome. However, unlike anemia, we do see a protective effect of older age, as well as consumption of bouillon and ready-to-use therapeutic foods or nutritional supplements. Interestingly, having had a fever in the past 2 weeks or having wasting were protective against ID. And a possible explanation for this is that even though we did adjust ferritin levels for inflammation using the Brinda adjustment, it was imperfect. And these results reflect the effect of residual inflammation that the children have and which is leading to hypothermia. Similar to anemia, consuming clay or soil, also known as pica, as well as maternal burden of iron deficiency were associated with higher odds of the disease in the children as well, as were serum folate and zinc deficiencies. Finally, among children, we also looked at the correlates of iron deficiency anemia. And then from the hierarchical multivariate model that you see presented on this slide, we found that similar to anemia, women's education or maternal education was protective against IDA, but having access to improved drinking water was not. Similar to iron deficiency, older age was also protective against iron deficiency anemia, as was consumption of bouillon. And once again, we see that history of illness, in this case, having had cough in the past 2 weeks, is protective against IDA, as was wasting. While pica practices, once again, the maternal burden of iron deficiency anemia, having stunting, and B12 and serum folate deficiencies were all associated with higher odds of having IDA or iron deficiency anemia in children. So when we put all these models on one slide to see what are the common factors across these 3 outcomes, we see that you will see that the determinants or correlates that are common across all 3 outcomes are highlighted in bold, while those that were common for 2 outcomes are underlined. So the first one that was common across all 3 outcomes is pica, or consuming clay or soil during the last week. Furthermore, the maternal burden of disease. So for anemia as the outcome, the mother having the anemia was associated with higher odds. For iron deficiency as the outcome, the mother having the iron deficiency was associated with higher odds, and so on with iron deficiency anemia as well. Women's education, there were no underlying causes associated with iron deficiency, as we talked about in the iron deficiency specific model, but we do see that women's educational attainment, or again, maternal education, was associated with anemia and IDA. Amongst the anthropometric indicators, stunting was associated with both anemia and iron deficiency anemia, while wasting had a protective effect against iron deficiency and iron deficiency anemia. And amongst the biological causes, we see that serum folate deficiency is associated with higher odds of all 3 outcomes among children, whereas B12 deficiency is associated with higher odds of anemia and IDA. And of course, iron deficiency and malaria remain significantly associated with anemia among children. We also looked at all 3 outcomes among women of reproductive age and non-pregnant women of reproductive age, since, as Maria Elena mentioned, even in a population-based survey, the sample of pregnant women is too small to conduct any statistically valid modeling exercises. So this slide summarizes all three outcomes among the women. And once again, the results highlighted in bold are associated with all three outcomes, while those underlined are associated with at least with two. Among women, that we see that similar to children, pica practices were increased with higher odds of all three outcomes. While current use of modern contraception was actually protective against not only anemia, but also iron deficiency, as well as iron deficiency anemia. Among the underlying causes, not having attended school was associated with iron deficiency, as well as iron deficiency anemia among women, while the main construction material of the dwelling of flooring being earth, sand, or dung compared to a finished flooring was associated with, was protective against iron deficiency and iron deficiency anemia. And we believe that this again speaks to a higher infection burden, which is causing the body to sequester iron and leading to high serum ferritin levels in the blood. So the only anthropometric indicator that was associated among women was being overweight or having a BMI of greater than or equal to 25. And that was found to be protective against anemia. While amongst the several biomarker data that we had available, we see that zinc deficiency among women is associated with all three outcomes, while vitamin A deficiency is associated with anemia as well as iron deficiency. And of course, for anemia, iron deficiency, serum folate deficiency, and malaria continue to play a very important part, and having any of those significantly increase the odds of anemia among women as well. So in Burkina Faso, we also collected population representative data on adolescent girls as well as boys, 10 to 19 years. So this slide summarizes the results of the modeling for girls looking at anemia, iron deficiency, as well as iron deficiency anemia. And for girls, it was not going to school or no education that was associated with higher odds of the outcome for higher odds of the disease for all three outcomes, as well as being older, so 14 to 19 years, which makes sense because that is the time when girls are reaching puberty, they've reached menarche, and the menstruation, as we've heard throughout the day today, can lead to blood loss and iron deficiency. And interestingly, having had diarrhea in the past 2 weeks was also associated with higher odds of all three outcomes amongst the girls. Pica practices were also associated, but only for iron deficiency and iron deficiency anemia. And this is different from what we observed for children and for women. And then finally, vitamin A deficiency among girls was associated with all three, was higher odds of all three outcomes. And again, we see that iron deficiency and malaria are highly associated with anemia as an outcome. Manuela, can you forward the slide? Thank you. For the boys, we see an effect of household wealth and belonging to the fourth or fifth quintile was protective against all three outcomes for the boys, and belonging to a food secured household was associated with lower odds of anemia and iron deficiency only. Age was also associated with anemia and iron deficiency anemia, older age. And again, this is also the age where the boys are also growing and their bodies need additional nutrients. So it's not surprising that older age is associated with higher burden of disease. And interestingly, we had for iron deficiency and IDA, we did not see an effect of either malaria or vitamin A deficiency as we did for the girls. but similar to the other three population groups, iron deficiency and malaria remain a significant risk factor for having anemia. So what are the key takeaways for Manuela? I may just ask you to forward the slide. Thank you. So what are the key takeaways from Burkina Faso for anemia across the population groups that we had data on? As I said previously, iron deficiency and malaria are consistently associated with anemia among all population groups, which does give us an indication of potential control avenue for anemia control programs. We also saw that pica was associated with higher odds of anemia among women and children. For both women and children, folate and zinc deficiencies were also associated with anemia. We couldn't assess that relationship among the adolescents because we did not collect that data. And finally, for women as well as girls and boys, vitamin A deficiency was also associated with anemia. And an interesting fact in Burkina Faso is that there is a vitamin A supplementation program for children, which could be a reason why we do not see an association, or we do not see vitamin A deficiency as a major cause of, or a major determinant of anemia. Among those variables or correlates that were associated with a decreased odds, there were none that were common across all four population groups. In terms of having household having access to improved water and or sanitation services, for children and boys, that was important for being associated with lower disease. Whereas for women, contraceptive use was also significantly associated with less anemia. Next slide, please. So we then decided to look at all three outcomes across a single population groups. So the upper part of this slide shows the commonalities for children across the three outcomes. And the main takeaway here is that, again, pica, the maternal burden of disease, as well as folate deficiency is associated with all three outcomes among children. Whereas maternal education, consumption of ready-to-use therapeutic food, consumption of bouillon, and older age are associated with two of the outcomes that we looked at. For women, contraceptive use was also protective against all three outcomes, while pica practices and zinc deficiency were associated with higher odds of all three outcomes. And vitamin A deficiency was associated with anemia and iron deficiency. Next slide, please. For adolescent girls, again, it was not going to school, having reached menarche and having been ill in the past 2 weeks. That was associated with all three, higher levels of all three outcomes, where malaria was also associated with anemia as well as iron deficiency. And for the boys, household wealth was protective for all three outcomes, and food security was important for anemia and iron deficiency. For boys, we also see an effect of the household cooking with sodium bicarbonate, and the use of sodium bicarbonate in cooking being a risk factor for iron deficiency and iron deficiency anemia. Next slide, please. So now I will present some of the work that we did with anemia exemplars using Senegal as the case study. And as I've said before, many thanks to Dr. Zulfi Bhutta and Dr. Ndiye Fatou of Lorna for allowing me to present on their behalf. Next slide, please. So what are the exemplars in global health? The exemplars are based on the premise that the quickest path to success scale is to identify who has already been successful, find out why, and try to adapt their strategy to your own context. So the Exemplars in Global Health program aims to help guide public health decision makers at the country and regional level and help them to make policy decisions through this process. Next slide, please. So how do we define an exemplar? An exemplar is a positive outlier or a country that has shown or that has outperformed their peers in a particular indicator of public health. And they have succeeded beyond what might be expected given their country context as well as the financing that was available to them. Next slide, please. So a brief information about etiology of anemia among women in Senegal. Between 2005 and 2017, anemia prevalence declined by 5 percentage points in the country from 59% to 54%, and this was the second highest in Western Africa. However, anemia remains a severe public health problem, and malaria remains endemic in the region. From 2005 to 2017, the incidence of malaria also decreased significantly in the country, and that is also reflected in the etiology that was modeled by the Global Burden of Disease, where the proportion of cases due to malaria decreased from about 182 to about 133 during that time frame. Next slide, please. So in terms of the methods, next slide. We conducted a systematic, in-depth assessment of the determinants of anemia in Senegal at the national, community, household, and individual factors, level factors, as well as identified relevant nutrition-specific and nutrition-sensitive interventions, innovations, policies, programs, and strategies that could have had an impact on anemia among women of reproductive age between 2005 and 2017. Next slide, please. Our research was guided by the conceptual framework that you see on your slide. I think we've seen maybe 10 conceptual frameworks for anemia during the course of today. But this also assigns each of the several determinants of anemia into one of 3 levels. The distal causes, which are the further out from the outcome, followed by immediate causes, and then the proximal causes, which are most closely related to anemia. Next slide, please. So it was a mixed methods approach with several complementary approaches that we carried out. The results I will be presenting today are specific to the multivariate regression and specifically the Owais blinder decomposition methods that we used to identify and quantify the relative contribution of the key drivers of anemia decline in Senegal. Next slide, please. So we conducted a linear least square regression model with hemoglobin as a continuous outcome, accounting for survey design and weights as appropriate. We defined our outcome as hemoglobin for an individual woman at an individual time, with X being the time varying determinants. We also controlled for the time invariant region, as well as the survey year, and standard error term was used with the assumption that error term has mean 0, and we also assumed that the betas are the same across the 2 survey years. Our hierarchical approach for model building was based on 2 levels. Specifically, level 1 included the intermediate factors, which accounted for the socioeconomic factors and the healthy household environment, followed by proximal level factors, which were the women's characteristics as well as their healthcare utilization practices. And our final hierarchical model included intermediate causes, which had a p-value of less than 0.15, and proximal causes with a p-value of less than 0.15. Next slide, please. So then we extended our linear regression model to Owais blinder decomposition, which which calculates the predicted change in hemoglobin and multiplies it by the mean difference in the determinant that was observed. So the beta in this case is the coefficient from the linear regression model that I showed you in the previous slide, and the mean difference in the determinant is the mean difference, for example, for IFA consumption during last pregnancy. The beta estimate for IFA consumption in last pregnancy was multiplied by the increase in coverage of IFA consumption between 2017 and 2005 to calculate the predicted change in hemoglobin associated with increase in coverage of IFA consumption, which was then ranked to identify the relative contribution of each determinant. Next slide, please. Next slide. Thank you. So the key drivers of anemia decline in Senegal were improvements in coverage of maternal healthcare access, specifically consumption of IFA during last pregnancy, as well as receiving 4 or more antenatal care visits, which altogether explained about 26% of the change our model was able to explain. This was followed very closely by improvements in indicators of family planning, which were increase in the use of modern contraception, as well as a decrease in parity. And last but not least were the impact of malaria prevention program, including bed net use and IPTP during last pregnancy. We also saw an impact of women's education and their empowerment as being positive for hemoglobin increase. And then finally, a decrease in the proportion of households practicing open defecation was also associated with an increase in hemoglobin in Senegal. Next slide, please. So having done these two analyses, what can we say about the drivers of anemia among women in West Africa? So there were several common correlates that were identified in both Burkina Faso and Senegal, specifically household socio-demographics. In Senegal, it was the household wealth and reduction in the practice of open defecation. And in Burkina Faso, specifically, it was household food security. Both countries saw a positive effect of contraceptive use. And finally, malaria prevention programs also have it was either malaria infection in Burkina Faso or malaria prevention in Senegal that was associated with anemia or anemia decline in Senegal's case. Next slide, please. So additional correlates were identified based on what data we had available in each of the surveys. In Burkina Faso, we also had captured data on dietary diversity for women, and we did see an effect of women consuming a minimum dietary diversity and that leading to a lower burden of anemia. We also saw an impact of their micronutrient status as well as their body mass index, which could be considered a proxy for their overall nutritional status. In Senegal specifically, we saw an impact of improvements in women's education and social and economic empowerment, and of course, pregnancy care and history that could have a longer lasting impact than just birth outcomes and can lead to improved hemoglobin levels in women post-pregnancy as well. Next slide, please. Of course, as with any other statistical analysis, there were strengths and limitations. Both Burkina Faso and Senegal use cross-sectional surveys, which limit our ability to draw causal inferences. In other words, association does not mean causality. However, we did create panel datasets in Senegal using 2 survey years, which allows us to assess the effect of improvements in potential determinants of anemia over time. In Burkina Faso, we had to exclude the Sahel region due to security concern. And then in Senegal, we did not have data on women's diet or their height or weight especially in the 2017 DHS. So we could not assess the impact of women's overall nutritional status on their hemoglobin levels. There is the issue of generalizability of results as well. And please forgive me if I get the geography wrong, but I believe both Burkina Faso and Senegal are in the Savannah Belt. So these results may not be generalizable, or may have, the associations may have different strengths in other parts of Africa. Also for Senegal, the blood source was capillary for both DHS, and as we know that there is measurement error that is associated with finger prick blood source. However, the measurement inaccuracy, we believe, was somewhat mitigated by using hemoglobin as a continuous outcome as opposed to anemia as a dichotomous outcome. So the increase in hemoglobin, mean hemoglobin that was observed in Senegal is most likely or less likely to have a random or systematic error as anemia as a dichotomous outcome would be. And the major strength for Burkina Faso was, of course, the blood source was venous. So our results of hemoglobin and therefore anemia estimates are more valid and reliable. Next slide, please. So what can we say about the way forward for anemia reduction among women? So there is emerging evidence that is consistent across what drives anemia among women of reproductive age. We have examples from Africa, of course, Burkina Faso and Senegal that I shared with you. Uganda was also part of the Anemia Exemplars program. And then we also have data and results from other anemia exemplar countries, specifically Mexico, Pakistan, and the Philippines. And there are consistent themes emerging across all these analyses. We see a positive effect on improved family planning and healthcare access for women, as well as malaria prevention programs in endemic regions. We see improvements in food security and improved diet can also lead to improvements in hemoglobin levels and anemia decline. And of course, women's empowerment and education, as well as access to improved water and sanitation services. We also have additional evidence from Burkina Faso where micronutrient deficiency, especially iron, increase the risk of anemia, but there are other micronutrients, specifically vitamin A, serum folate, and zinc deficiencies that can also lead to anemia among women of reproductive age. Next slide, please. I think that may be the last. Yes, thank you very much. I don't know how I did for time.